Hello everyone and welcome to our module on hyperaldosteronism. Primary hyperaldosteronism refers to excessive levels of aldosterone secretion from the adrenal glands, not due to increased activity of the renin-angiotensin-aldosterone system or the RAS. This can happen for a couple of reasons. Sometimes patients develop an adrenal adenoma, which is a small portion of the adrenal gland that overproduces aldosterone. When this happens, it's sometimes referred to as Conn syndrome. Primary hyperaldosteronism can also occur if there's bilateral idiopathic adrenal hyperplasia, where the glands just become large and produce too much aldosterone. And then rarely, in less than 1% of cases, an adrenal carcinoma, which is a malignant tumor of the adrenal glands, can produce aldosterone, leading to primary hyperaldosteronism. To understand the clinical features of hyperaldosteronism, we have to review what the hormone aldosterone does. So it functions in the collecting duct of the nephron, and it increases sodium resorption from the urine so that there will be increased sodium in the plasma. Anytime you reabsorb more sodium from the nephron, that will increase the circulating volume in the body, and that will lead to hypertension. Aldosterone also promotes potassium excretion in the urine, so patients with hyperaldosteronism can develop hypokalemia. And aldosterone also increases acid excretion in the urine, so when you have hyperaldosteronism, more acid is excreted from the body, and therefore a metabolic alkalosis can develop with a high serum bicarbonate. And I've summarized these things at the bottom of the slide here. Aldosterone pulls sodium from the urine into the blood, and it causes the excretion of acid and potassium into the urine. So if you understand what aldosterone does, then it's easy to understand the clinical features of primary hyperaldosteronism. These patients tend to have resistant hypertension, and that's because they're constantly reabsorbing sodium from the urine. They may have hypokalemia, although this is an inconsistent finding. Less than 30% of patients with primary hyperaldosteronism have hypokalemia in some studies. And that's because even though the aldosterone level is high, if patients are consuming lots of potassium, they may still have a normal serum potassium level, and they won't necessarily have hypokalemia. And then lastly, patients with primary hyperaldosteronism have a normal volume status on physical exam, meaning they don't have lower extremity swelling or pulmonary rales. And the reason they have a normal volume status on physical exam is because of a phenomenon known as aldosterone escape. So aldosterone escape refers to the fact that excess aldosterone does not lead to volume overload. You might think that because aldosterone causes the reabsorption of sodium and water, that patients would be swollen when they have hyperaldosteronism, but they don't, and that's because of aldosterone escape. Usually patients with hyperaldosteronism do not have pitting edema or rales or increased jugular venous pressure. The only evidence they have clinically of sodium and water retention is hypertension. The reason for this is because when hyperaldosteronism causes fluid retention, compensatory mechanisms are activated. In particular, the heart releases atrial natriuretic peptide, which increases sodium and free water excretion in the urine, and this combats some of those effects of volume retention caused by high aldosterone levels. So because of these compensatory mechanisms like increased ANP, patients with hyperaldosteronism will have some diuresis, and this will allow them to maintain a normal volume status on physical exam without any signs of volume overload. And this phenomenon of escaping from volume overload in the setting of hyperaldosteronism is called aldosterone escape. The diagnosis of primary hyperaldosteronism is usually suspected in a patient with resistant hypertension that is not responding to treatment with one or more medications, especially if the plasma potassium level is low. To make the diagnosis, you need to demonstrate renin-independent aldosterone secretion, and by this I mean you need to demonstrate that the aldosterone level is high, but that the activity of the renin-angiotensin-aldosterone system, or the RAS, is low, and this means that the RAS is not what is driving the high aldosterone level. There are two blood tests that are usually used for this purpose. The first is the plasma renin activity. It will be low in primary hyperaldosteronism. Usually it's less than 1 nanogram per milliliter per hour. The other blood test that's usually ordered is a plasma aldosterone concentration. This will be high in primary hyperaldosteronism. Usually it's greater than 15 nanograms per deciliter. And then in many cases, the ratio of these measurements is determined, the ratio of the plasma aldosterone concentration to the plasma renin activity. If it's greater than 20, that suggests the patient has primary hyperaldosteronism. When the plasma renin activity and the plasma aldosterone concentration suggest a diagnosis of primary hyperaldosteronism, confirmatory testing is usually done. The idea here is that you need to demonstrate that there's inappropriate aldosterone secretion by the adrenal glands. This is usually done by giving the patient an oral sodium load or a sodium infusion. When you add sodium to the body, this should suppress aldosterone release. This should expand the extracellular volume, and it should cause less renin release from the kidneys and less aldosterone release from the adrenal glands. So after you administer a sodium load, you can measure the urinary aldosterone excretion or the plasma aldosterone concentration. If these levels remain high after a sodium load, then that's a positive test, and it means that the patient's adrenal glands are producing aldosterone even in the setting of a high sodium load, and that's abnormal. That means there's something in the adrenal glands causing them to over-release aldosterone, and that's evidence of primary hyperaldosteronism. Once you know that the patient has primary hyperaldosteronism, you need to determine the cause. The test that's usually done for this purpose is an abdominal CT scan. It can identify either an adrenal mass, which could be an adenoma, or bilateral adrenal enlargement if there may be idiopathic adrenal hyperplasia. There's also an interventional radiology procedure that's often done called adrenal vein sampling. This is where a separate blood sample is obtained from each adrenal vein, one from the left and one from the right, and you measure the level of aldosterone in the samples. This is useful for distinguishing unilateral from bilateral disease. If the aldosterone level is very high in one sample but very low in the other, then the patient has unilateral disease. If it's high in both samples, then the patient has bilateral disease. And the reason it's important to know whether the disease is unilateral or bilateral is because that has an influence on treatment. When patients have unilateral disease involving only one adrenal gland, the treatment is with surgical adrenalectomy. The patient will still retain their other adrenal gland, which can continue to function. If there's bilateral disease, however, the treatment is medical therapy because you don't want to remove both adrenal glands. The drugs of choice are spironolactone or eplerenone. Both of these drugs are aldosterone antagonists, and they will block the effects of high aldosterone levels. Incidentally, if you try to use ACE inhibitors or angiotensin receptor blockers, those will have no effect in these patients. The reason they have no effect is because the angiotensin II levels in these patients are already very low. They have very low RAS activity and very low levels of A2. For this reason, inhibiting the RAS system by using either ACE inhibitors or ARBs usually has no effect and doesn't improve the blood pressure. And that's because these patients have aldosterone release that is not dependent on angiotensin II stimulation. Now let me tell you about a disorder that looks just like hyperaldosteronism, but it's not, and that is the syndrome of apparent mineralocorticoid excess, or SAME. The idea behind SAME is that the cortisol in our body produced by our adrenal glands can bind to renal aldosterone receptors and could produce a strong aldosterone or mineralocorticoid effect. But it doesn't do this because cortisol is converted into cortisone locally at the level of the kidneys by renal cells. There's an enzyme in the kidneys called 11-beta-hydroxysteroid dehydrogenase, and this converts cortisol into cortisone, and cortisone does not have the same mineralocorticoid actions as cortisol. So in patients with the syndrome of apparent mineralocorticoid excess, they have a deficiency of the enzyme 11-beta-hydroxysteroid dehydrogenase, and as a result, cortisol persists at the level of the kidneys, and it produces aldosterone or mineralocorticoid effects. SAME presents in children or adolescents with a clinical syndrome that is similar to hyperaldosteronism, so this includes hypertension, hypokalemia, and metabolic alkalosis. And when you see these things, it may make you think of hyperaldosteronism, but when you measure the plasma renin activity, it will be low, and the plasma aldosterone levels will also be low. And that's because the renin-angiotensin-aldosterone system is dialed down, and all of the mineralocorticoid effects are coming locally from cortisol at the kidneys. And the treatment often involves potassium-sparing diuretics. These are drugs like amiloride or spironolactone. All of the potassium-sparing diuretics inhibit mineralocorticoid effects at the level of the kidneys. And you also should be aware for your board exams that licorice, which is a candy like shown here on the screen, it's also found in some teas, contains a substance called glyceretinic acid, which is a steroid. This steroid has a weak mineralocorticoid effect, and it also inhibits the renal enzyme 11-beta-hydroxysteroid dehydrogenase. So patients who consume large amounts of licorice, either as candy or in teas, can develop disease similar to the syndrome of apparent mineralocorticoid excess. So they can develop hypertension, hypokalemia, and metabolic alkalosis. And just like in patients with SAME, they will have low plasma renin activity and low plasma aldosterone levels. And then we'll finish this video with one slide on secondary hyperaldosteronism. This is also called hyperreninemic hyperaldosteronism, and it can lead to resistant hypertension and even hypokalemia, just like primary hyperaldosteronism. But in secondary disease, there's an elevated plasma renin activity. When you get this finding of an increased plasma renin activity, it means that the kidneys are releasing too much renin, and that's what's causing hyperaldosteronism. This usually means the kidneys are being underperfused for some reason, and they're sensing that low perfusion and they're activating the renin-angiotensin-aldosterone system. So this could be because of renal artery stenosis. This can be seen in patients who have heart failure or cirrhosis, and then it's rare, but patients can have a renin-secreting tumor. But the bottom line here is when you find elevated plasma renin activity, you know you are not dealing with a case of primary hyperaldosteronism. You have a case of secondary disease, usually due to one of these causes listed on this slide. And that concludes our module on hyperaldosteronism.